Good morning, everyone. Um, we think there'll be some more people joining, but we also know that this particular session is going to be pretty lightly attended because we've had actually good outreach from hospitals around setting up individual meetings with Pascal metrics, and so I think that's at this point. That's probably where most people are looking to get the information. What we're going to do today, and we are recording it. So for those people who do want this, this particular information and aren't able to make it today, we'll just go quickly through the presentation. So Charlie's going to just walk through what the process is from here on out, and then the folks from Pascal Metrics are going to talk more about just readiness, sort of a self-assessment, what you should be thinking about in terms of being, ready to embark on as a pilot site, and then it's just open questions, and if and we may not need the whole hour, which is I'm sure always welcome to everyone if there's time given back. So without further ado, Charlie, why don't you take it away?
Sure. All right. Thank you, Barbara. So I'll speak a bit about the application process and how we'll move forward from end of the information sessions through the final selection of pilot hospitals and how we'll enter into agreements with them. And then the Pascal team can talk a bit about their experience around hospital readiness, and we can answer any final questions. Just basically what we're looking at is we're wrapping up the information sessions now, and the next step will be we're scheduling one-on-one meetings with hospitals to really talk more deeply about their interest, give them a chance to ask specific hospital-specific or system-specific questions of Pascal, and really make sure that the pieces are in place to successfully become a part of the pilot. I should say, so far through the information sessions, we've had engagement with people representing over 30 of the acute care hospitals in Massachusetts. So pretty exciting, a lot of participation up to this point. We're now setting up those one-on-one, those one-on-one meetings with Pascal and the Betsy Lehman Center. We're scheduling those from really next week through mid to late June. Some of Pascal's advice around those one-on-ones is, if possible, it'd be very helpful to, in addition to the quality and safety leadership from the hospital or the system, having someone attend who is in a clinical strategy and clinical operations position, so they can really talk about and understand the implications of the pilot for care design, as well as the clinical teams and their day-to-day work. And then, so typically a CMO, a CNO, or similar. And then ideally, it can be helpful to have someone who's in a risk management leadership position, and even someone from your IT leadership who might have questions about just the software implementation and then the analytics integration processes. So we can go through all of that in detail when we talk about setting up one-on-ones, but we already have some of these one-on-ones scheduled. So we're just trying to make sure that schedules line up for the next month or so. We'll be, as I said, we'll be meeting with people through June, and we'll be working toward a key milestone in July, where we are asking interested hospitals to submit what is basically, it's a formal expression of interest through a document that we're just calling an application proposal. So we will be providing all hospitals with a basic template that just sets out a series of questions that we'd like to have some answers to, just to help us understand a hospital's readiness, their interest, any of their concerns that they might have, and also some prompts around leadership support for pilot participation, as well as existing systems and structures for safety improvement within the hospital. It's intended to be a document where the hospital can attest to its understanding of the responsibilities that are laid out in the hospital prospectus, but also a chance to really start talking about what a hospital wants to get from participating in the pilot. And once we have those documents in hand, we will have follow-up meetings with all of the applicants just to answer any final questions, have an opportunity for us to explore a bit more your answers. And once we have all that final information in hand, we will have a selection committee that goes through the information that we've collected through our meetings and through the application proposal. And that selection committee it will be composed of a small group with representatives from our team at the Betsy Lehman Center, from Pascal Metrics, as well as some representatives from the Pilot Advisory Committee. So these are individuals who are external to the Betsy Lehman Center, to the state, and they have a lot of expertise in the field. And they can bring a unique perspective and they have been bringing a unique perspective to all our planning through the launch of this pilot. So this group will be making their decisions in July to August, and then we'll be going through a finalization of agreements with hospitals into early fall, with the goal of having an MOU between the Betsy Lehman Center and pilot hospitals in place by end of September. And Pascal will have a separate set of agreements with each of the pilot hospitals. That's really unique to Pascal's status as a PSO and just given the type of vendor that they are. So they'll have a business associate agreement, a statement of work, and there's also a PSO framework document that really communicates the roles and responsibilities of each party as they'll be working within that PSO environment. So this is the timeline that we're working with. And things might, we put down some dates. Things don't necessarily have to be this strict. We can be a little bit loose, but what we're looking at, we're wrapping up the informational webinars today. We'll be scheduling our one-on-one meetings with interested hospitals. I said through mid to late June. We can certainly meet with people through July, but we're really aiming for a deadline of July 15th to have those application proposals submitted by hospitals to the Betsy Lehman Center. And then we'll be setting up follow-up meetings with each of the applicants for us to do a little bit of an interview, answer further questions, explore the information that was shared in that application proposal. And we'll do that through mid-August and recognizing that it is summer and we're going into high vacation period, especially the later part of August. And then our selection committee, they'll take all that information in hand. They'll make their decisions. We're saying by August 19th. And what we hope to do is put together a cohort of 6 to 8 hospitals in Massachusetts that really represent the variety of types of hospitals and settings across the Commonwealth. And I would say that already from hospitals that are setting up one-on-ones with us and expressing interest, we've really gone a long way toward already representing the state of the acute care system in Massachusetts. So we're very optimistic and pretty excited about where things already stand. At that point, we provide our documents to hospitals. And as I said, we'd be looking to get agreements in place by the end of September so that we can really hit the ground with the next phase of work in October. And that next phase of work is Pascal really engaging with hospitals, doing the software implementation, and moving from there into actual integration of the data and clinical validations with hospitals. So that is the process that we're looking at. Certainly happy to take questions about this. But before we do that, why don't we hold questions for the end, as Pascal is just going to briefly speak to some of their suggestions around hospital readiness. And this really shouldn't take too long. We don't have any slides that we need for this. So we can take the slides down and I'll turn it over to Pascal just to present briefly around hospital readiness.
Sure. I mean, I could start from a technical perspective. Obviously we want organizations that have a somewhat stable electronic health record. So, not just fresh coming off and integrate a migration to a new vendor. So a little bit of stability there. We have worked with most vendors, so that's not going to be an issue. The only thing we rely on is, I think we've talked about this before, is getting what we call HL7 data interfaces from your vendor to our data center. Most organizations already have a series of outbound interfaces going a variety of different places. So we just ask that they kind of clone that and point a copy of it to us. So it shouldn't be a big lift from an integration perspective. We have about 10 different types of interfaces that we look for, stuff you would imagine, like ADT registration, lab and micro data, radiology, the text data, surgery, knowing when the patient went to surgery, discrete kind of flow sheet data, as well as text notes. So, progress notes, op summaries, those kinds of things. And then coding, kind of knowing, what procedure codes were added to the record once the patient was discharged. Obviously, one of the people we would want to make sure we have engaged early in the project is the CIO, just to kind of make sure this is on their radar and they were able to assemble the resources we need when we're ready. And then David, you want to talk about from a operational perspective?
Sure. I think probably the first criteria would be a high level of interest, and I assume that you all have that, or you wouldn't be hanging with us through these 4 sessions to this point. The next step, and I apologize for my background and being off camera, I'm at an airport, so sorry for airport noises. If the way, I think we talked about this a little bit, but the way to think about what you do and how you will interact with this is similar to what you likely do with your voluntary event reports, meaning that once they're created, a voluntary event report, once it's created, I assume that somebody in your hospital may, either on a quality team or safety team, may be reviewing those and trying to escalate those if they seem like that they are ones that need action, or if they represent some trends. That's largely what you're going to be doing with our system. The data will flow, the safety events, they're gonna be there. It really works best if, with the individual that we mentioned before, the role that we call the patient safety liaison, that's a hospital employee. That's not a Pascal employee. That's an individual who's really, hopefully like it sounds, the liaison between our team and your team, and then puts those documents, the adverse events documents that our team creates, into the mailboxes of the people that are most relevant for your organization. It's a pretty simple task. I think we demoed it. Excuse me. We've talked about it. And I assume, again, it's somewhat similar to how you manage your voluntary event reporting systems. There will be more. There will be more than what you're dealing with now. And so in terms of your clinical operational readiness, yes, you do need to have, hopefully, the capacity to try and change something on your side. Like I said, the safety events are going to be identified, so you don't have to necessarily worry about that. We do, especially when cases seem like they have a high potential to be associated with high severity, and they look like they have potential to be preventable. There are times when we engage with the hospital through the liaison. They are not typically the people that are answering these questions, but we may say, you know what, this looks like this may be a preventable event to us. We don't see anything in the record about situation X. Maybe we see a little bit, or at least a piece of a puzzle, but the whole puzzle isn't in the record yet. One, we're going to want to get that into your hands so that you're aware as soon as possible. And 2, we do like to collaborate with your teams to try and answer the questions, the 3 categorization questions that we do: the type of harm, the severity of harm, and the preventability of that harm. And so it's really best when our team and your team are engaging through our software in our comment section of documents, and we can go through that when we do the individual demos or the individual meetings with you all. But that to us really shows a lot of engagement, but I think it's also how you're going to get the most out of it. So hopefully that helps to think through a little bit about capacity and interest. And again, the safety events they're going to be there. We're gonna use all the information that we have to make the judgments that we can on those classification questions, whether things are an event or not. And then those 3 questions I mentioned before. And it would be great to be able to work with you all if that sounds like a journey that you would like to start to learn much more about the patient safety events that are occurring in your hospital. And I am a practicing clinician. I've worked in quality and safety for more decades than I want to admit. I know that the volume of voluntary event reports can be a lot, and we're saying to you, hey, guess what? There's more. What I think is the good thing about this, what we all think is the good thing about this, is that you will see these events and there's no regulators that are forcing you to do anything here. You will get to prioritize where your precious safety and quality resources are distributed. Where do they go and do the work of improvement? And hopefully the identification will give you a head start in that. That's how we've designed it. That's how we've tried to describe it in these calls. So I'm trying to lay out that you will have choices about which of these types of events that you want to work on. These events are happening already. They just may escape your identification if you're like every other hospital that we've ever worked with. But you will have the ability to make those decisions about this one we need to work on, and this one we need to work on, and this one we can wait a little bit and see if this is a trend or if something turns into something more severe later. And that is a different way of doing safety, I know, but I think that it is really a next step in the safety maturation cycle, because you're able to triage for yourself where to place those resources, like I was saying before. So hopefully that's helpful. And I know I can speak for Susanne and say that we're happy to take any questions that you all would like.
Thanks, David. I think that last part of David's, that actually echoes already one of the major concerns that we've heard from hospitals that are interested. They're interested, but they're not certain about whether they can take this on. Setting aside the EHR maturity issue, I think most hospitals know whether or not they're there. A lot of hospitals just don't know that they can manage with this new source of information about what's happening in the hospital and bring it into what their staff are already doing. I think something that's unique about the pilot is we're working with Pascal because Pascal offers not just the, and through the pilot, we're not just offering the data, but that full stack of support to help hospitals have the greatest likelihood that they're successful in using the data. I think that it's worth, even if a hospital is concerned about that volume of data and the variety of events that they're learning about, that there will be support to work with that new information and bring it in a really measured, thoughtful way to help hospitals prioritize and not just understand what's going on, but really take a targeted approach to using the analytics. So that's what we have. We're very happy to take questions at this point.
So one quick question. I know I'm going to ask a pretty site-specific question since I know we're kind of overrepresented today. So at our organization, we generally have to put resources in to build HL7 interfaces. That's just the way our IS team works. Is usually it might cost like 30 grand or something. I know that the Pascal metric solution is being covered by the state, so there's no charge there. But what about the HL7 build part of that? Is that something we'd have to just take on in the organization?
Susanne, can you answer that question? There isn't additional funding for that, but I'm not sure what's actually required in this instance. Suzanne, do you have a?
Yeah. I mean, we try to minimize the impact. I mean, I hear you. A lot of organizations say, no, we build them from scratch, which I hate to hear because I think that's not the best way to approach it. Once we could convince them to clone an existing feed, really we don't ask for much. It's only if that feed really is missing a key thing like a patient identifier that we would really require any changes. So up front they think, oh my God, this is this much work, but then they realize it really is only this small amount of work. And I think that's part of the reason we do want your CIO involved early on in the project, just to try to get that understanding of what the lift is. That we can minimize that as much as we can. I know we didn't answer your question about who's covering the cost of your IT resources.
Yeah, it seems like we'll just have to eat that cost. I think I think it's just a way that we do these things that, you know, it's the accounting of it that we'll have to deal with. Not all organizations do it that way. I recognize that. So
yeah, and your IT, are they a central, you know, each hospital has the resources? Is it
no, it's system.
Okay, sorry, I missed you. System.
Any other questions at this point about the process, about the time frame, anything else? Because we, you know, I think really, I think most of the questions you're going to have at this point are a little bit more site specific, and which is why the one-on-one conversations are going to be the most useful.
I've got two quick general questions, if that's okay. Can you hear me
Sure.
well?
Yeah.
Okay, hi. My full name's Catherine, but I go by Kate, and I've had the opportunity to attend all of the sessions, and they've been super helpful, as are having the reference materials to look back on. One question is resource allocation wise for that liaison position. What do you recommend, or what do other hospitals have resource wise? Like, does a person need clinical training, or you know, your clinicians are vetting the reports? Is it pretty self-explanatory for let's like senior project manager to be able to field, to know where to send them, or do you think that person needs to be more senior, like you know, clinical or risk management type of liaison?
Suzanne, I'll start. If you want to throw anything in, please feel free. Typically, what we see is that the folks that are tapped on the shoulder are often nurses, often in a patient safety department or the quality improvement area. I think that probably a little bit more important than being a senior clinician is knowing the organization and knowing who might need to manage X, Y, and Z event. Where do they need to go? If they were gonna let a leader know that this event has happened for whatever microsystem, knowing who those people are is going to be probably one of the most important things. Like I said, there are times that we will ask clinical questions, but typically the liaison is just facilitating that. They're just moving that question on to the people that may have those answers.
Okay, or like in some organizations, it may be that a patient safety specialist or a risk manager is assigned a certain coverage area. So the liaison would, you know, contact that person who's like the front face person with that department or whatever.
That's right.
Have you found that other places have needed more than one liaison to handle the volume, or can one usually handle it with somebody like cross-trained to cover for vacation or something like that?
Yeah, good point. On the cross-training. Yeah, we've never had to have anyone have more than one person. It is a little bit of a clerical task, and it's not overwhelming. It's not adding hours and even multiple hours to anyone's day. Typically, we're only sending those events that have a decent likelihood of having high severity and preventability. The non-preventable events, we're not going to be assigning those to the patient safety liaison unless we just have difficulty classifying it. If we just need to answer one little question to help us get off the fence about whatever. But again, that person is just going to find the right person within your organization, put their name in, and assign them the document so that they can help to answer that question. So hopefully that makes it seem more manageable.
One additional thing is, you know, they're coming in a little bit more real time than like maybe a reporting thing. So you're going to get, you know, one here, one there, instead of a whole on slot. Now, you know, you might get a little bit more in the morning than you did, you know, the day before, but you know, it's generally a little bit more digestible because it's coming in, you know, at a normal pace.
And does our liaison with a clinician who vetted the information on Pascal's end? Or is it just like more of an automated send, or like a project manager person that's forwarding it to our person?
So it would be the person who reviewed the document. So the nurse that reviewed it would be the person that's assigning it to your patient safety liaison.
Okay, on your end. So the nurse on Pascal's
Yeah.
end.
Yeah.
Gotcha. Okay, and then my last question, and then I'll let other people pipe up if they would like to. To schedule the one-on-ones, do we do that through you, Charlie?
That's right. Yeah, I will
Okay.
we'll manage everybody's schedule to bring this together. So a good starting point is, if you're interested, feel free to just email me availability like out through mid-June. And I'm doing the same with Pascal, and we'll just try to line it up.
Okay, and we have an internal meeting on May 30th, and so we hope to get our plans together on our side by then, you know, on the sooner side, right after the holiday. So thank you. That was my last question. I turn the mic over to anyone else that may have any.
Well, Catherine, can I actually, your question raises another point that I thought I might make, if it's okay.
Of course,
Often our
please.
hospitals, you asked how do those things get assigned, and Susanne answered that the nurses on our team do it. Absolutely right. There will be people in your organization, I would imagine, if you're like most of our organizations we've worked with, that they just want to see those documents. So a reasonable example for me is the pressure injury team, whatever you may call that team. They want to know whenever anyone has been seen to have a pressure injury. And as we all know, the documentation of those things and the classification of those things can be quite technical, and we want to make sure we get them right. So the other feature that I'm pretty sure that we demoed is that if I'm the patient safety, if I'm the pressure injury nurse lead for your organization, and I want to know anytime Pascal finds one of those things in the medical record, just so I can kind of look at it and make sure that I know about it if I'm the lead, and that the information that's classified in that event is correct and consistent with what our team has seen, the pressure injury team has seen, then I can set up very simply. We like to think it's simple. I hope you would agree. Most people have that you can set up a notification system so that the pressure injury leader can get an automatic email anytime that document is created, so that our nurse reviewer, the Pascal nurse reviewer, won't even need to message that pressure injury team. They'll just automatically get a notification that there's a new pressure injury document in our system, and they can go right in to review it whenever they're ready to do that. And that's true for almost anything you can think of. You could set up those kinds of alerts to receive those notifications if you're somebody that manages falls, or if it's somebody like the safety pharmacist for your organization. The lead patient safety pharmacist wants to know about any medication related adverse events, any of those things. You can set up those criteria and have those email notifications show up in their inboxes the second that they are documented. So hopefully that's clear through our demo.
Okay, perfect. Thank you.
David, I just have a quick question. I'm realizing I don't know the answer to this. Typically, in your hospitals, how many different roles have access to the dashboard, and so they can go in and see whatever they want to see?
Susanne probably has a better sense of that, maybe even
Okay.
Sarah, but it's not every frontline person. This does not need to go to every frontline nurse, every frontline doc. It's the managers of those teams and the managers of the managers that we typically like to see. So Sarah or Susanne, what do you think? What are the average numbers of people that we have in our system for any given hospital?
Kind of just depends on how they, sometimes, you have departments and then other people find out about it and like, oh, wow, I need to know this as well. So it kind of starts percolating. But, nursing definitely have engagement, pharmacy, the different service lines obviously have engagement, wound care, as David mentioned, patient safety, of course. We've even had like at one facility, like lab managers, just because occasionally there are, events related to, specimen handling issues or not communicating results and stuff like that. So I don't know if that gives you a flavor for the kinds of departments.
So it's usually a range people who they're authorized to
Right.
log on and see what's in there. Okay. Okay. And as Charlie mentioned, really the next step, and where most of your specific questions are going to be answered is really through the one-on-one meetings. So very easy process. Just shoot Charlie an email saying, we're interested in having the conversation. It does not mean your executive leadership has agreed that you're in if you're invited to be in. But if you're seriously considering the opportunity and want to learn more about how you would engage with the system, then that one-on-one is going to be really important. I mean, I can tell you just in the conversations we've been having with some of Pascal's other hospitals around the country, it's just so interesting that everyone leverages the information slightly differently, sort of where, who's involved, what they're doing with it. It's all like, they're all finding quite a bit of value, but it's just interesting because as your organization, you are not cookie cutters of each other. Everyone's a little bit different. So these individual discussions will, I think, really help you sort of self-assess whether this is right for you to jump into. So unless there are any other questions, just thank you for joining us today. We're here, so just reach out if you need us, and we'll look forward to continuing the conversation.